It's great to have you be a part of the 2020 International Adenomyosis Summit. I'm Sarah Lopez, host of the summit and women's health coach. It's an honor to have Dr. Andrea Vidali joining us today. Dr. Vidali is a reproductive surgeon and endocrinologist, also an immunologist in New York City and New Jersey, and he's from Italy originally. He's a fertility specialist with over 20 years of experience and specializes in the surgical treatment of endometriosis and adenomyosis as it relates to pelvic pain and fertility. Dr. Vidali, thank you so much for joining us today. How are you?
Thank you for having me, Sarah. We're all, as you could see, we're all in kind of in a lockdown situation, right?
Yeah. Oh, it's crazy, huh?
Nevertheless, we're all working really hard, and I've been talking to patients and scheduling surgeries as well. It looks like things are gonna start turning slowly, but they will.
Oh, are you still doing surgeries during all this?
I'm gonna restart in about 10 days, more or less. Yeah.
Okay. Huh.
Yeah, because I found an outpatient facility where I can start working. Hospitals are still tough for a while, I think.
Yeah, absolutely. Well, that's good news. Up here, everything is closed, so.
Yeah. Yep.
Yeah. Well, I was wondering if you could share a little bit about how fertility can be improved when you have adenomyosis.
Well, I like to start, we got to start from the beginning, because I think that's just like, boom, yes, okay, yes. The answer is yes, it can.
Okay.
But, first of all, there are some things that need to be understood. Some of which, you may have discussed with some of the panelists that preceded me, but I think they need to be addressed, before we tackle the actual what we can do to solve the problem. The first thing that I think we need to discuss is that, the issue about what is really adenomyosis. And because your panelists already covered it, what I like to, there's one part that I like to say, and they may have said it, but adenomyosis is really an inflammatory condition, right? Regardless of the anatomical features of adenomyosis and the presence of the cysts and stuff that, in the uterus and all those things that people may have discussed ahead of me, what we need to understand is that adenomyosis is an inflammatory condition, as is endometriosis, but we're talking about adenomyosis today. And I think it's important to understand this because many of the features and the problems that happen with people with adenomyosis are related to this fact.
Yes.
It's not a mechanical problem. It's an inflammatory problem. Yes, the uterus is larger and can contract less and, so on. But the reality is that this stems from the fact that you're dealing with an inflammatory condition. Why? Because these islands of endometrial-like tissue that are planted deeply inside the muscle of the uterus and that distort the anatomy of the uterus are creating a constant process of inflammation. This is also present, and I'm going to share my screen with you right now, so you can just look at some of the stuff. Am I allowed to do this? Yes, I am. Hold on. Let me first find. Let me find what I need to find, and then we'll share the screen. And at some point, I may share some images that may be a little bit sensitive, but I will definitely give a trigger warning.
Oh, thank you.
To people. Just give me 1 second, okay? I'm just trying to find that image that I was looking for. Oh, here it is. Sorry about that. It just takes a second. Here they are. Just give me a second. Sorry.
No, it's okay.
It's live.
Yeah. No one has covered this yet. You're the first one.
Oh, I am the first?
Yeah. I don't know why, but it hasn't come up yet.
To cover, yeah, I think it needs to be covered because people who are watching us need to understand the fact that, just 1 second, sorry, just let me just quickly do this. It just takes literally a second. I'm sorry, because I was planning on sharing this with you, and then I realized that some of the things I wanted to show were not where they were supposed to be. And we're gonna pull them in here so that I know what I'm looking at. Beautiful. Okay, so I'm just gonna go ahead and share my screen with you guys. Of course, I'm about to show some images that relate. They're not like surgical images, but there are some histological images as well as some pathological images of surgical samples. So if you're sensitive to this, you know, obviously you may want to sort of like turn your screen or look away from the screen and just listen to me talking. All right, so here we go. Wait a second. Are you there, sir?
Yeah.
Okay, sorry.
Well, that's okay.
Zoom. Okay, share screen. You should be able to see my screen right now.
Yes.
Now, when you look at this image here at the center of my screen, you could see my cursor, right, as I'm looking. You could see that the appearance of muscle, which are kind of like those elongated cells that you could see in the picture here, those lighter pink cells. And you could see these are glands, you know, they have the classic glandular appearance, right? With the enlarged nuclei and like the cytoplasm. Many of you many of you who are watching this may remember this from college, right? The appearance of the glands, right? So you see your glands, you see this sort of like elongated cells. Those are muscle, right? That's the uterus is a muscle. And then you see all these little cells here, those little round cells with a very large eosinophilic nucleus. Those are inflammatory cells, okay? And it's very important to understand it. So like in our imagination, in our mind, when we think of this, we understand what's going on with this disease and how the inflammatory component of this disease is so important, okay? We need to remember that. And when you're actually looking at how this translates into imaging, it looks like this, okay? Where here you see the uterus. This is a sagittal cut, so it is as if I sliced a person down the middle, down the center, you know, and look at it sagittally, where you could see the uterus being enlarged, being asymmetrical. You can see that this part is much thinner than this part, where you can see this area here of thickening with those, you see those little cysts, that's a typical feature of the cystic endometriosis, which is really ultimately a larger version of this stuff here, where this grows, it gets inflamed and starts developing this pocket containing blood, fluid, and inflammatory fluid, okay? So that's how those cysts develop. And ultimately, when you're actually looking at a pathological surgical specimen, you see the same appearance, okay? So now we understand that what this disease is all about. It's not some mysterious thing. It is a inflammatory condition that exerts the pathological problems that are related to it, which we will discuss, due to the inflammatory problems, okay? Also, the other thing to remember is that it is a disease that progresses, okay? Endometriosis doesn't always progress. Adenomyosis has a tendency to progress more, certainly. In fact, although there's been adenomyosis described in very early in life, okay, even in children, it is, classically speaking, is more frequently found at a clinical level in the adult woman, more frequently than not, okay? That's a little bit different than endometriosis, because endometriosis is more it is frequently presents itself in the very young woman, but adenomyosis is more disease of the more adult woman. So it is more progressive, and also very frequent. I mean, like, you know, when you're looking at these pathological samples in random hysterectomies, you've seen incidence between 18 to 35%. But we're talking about small islands here and there. I mean, I'm talking about significant disease, the incidence is less. So what does this inflammation do? Okay, inflammation does what it does everywhere else in the body, which is it distorts the anatomy. It affects, it causes pain. Why? Because these inflammatory cells induce contractility of the uterus. And you're going to talk to somebody else about pain. So whoever's going to talk to you about this will address that part of it. And it will, and alters the mechanisms of implantation. And this is the biggest problem with endometriosis, with adenomyosis, which we will discuss in a little bit. But first of all, what are these symptoms of this inflammation besides the pain? Okay, let me tell you that as an expert, and I'm not telling you anything you don't know, obviously, because you're an expert in this, but obviously people who have adenomyosis experience such a wide variety of very severe symptoms. And it's not limited to pain. We're talking fever. We are talking elevated white counts. Typical presentation of severe adenomyosis is unexplained white blood cells on a regular CBC test. And the doctor's like, oh, I don't know why you have a white count. I don't know why you have an infection. No. White count is not only elevated because of infection. Sometimes it can be elevated because of inflammation. I see, for example, lots of people being treated with antibiotics. And I'm like, what are you doing? Right? This is not an infection. This is inflammation. These inflammatory processes affect fertility deeply. The first question that we ask ourselves then is, just one second, because I want to show you more. So I got to find the right slide for us. Does adenomyosis affect fertility? The answer is an unequivocal yes, it does. And this has been proven in multiple studies, not just purely in regular sort of irregular retrospective analysis, but also in a number of studies looking at IVF outcomes. And there's pretty consistent evidence that adenomyosis results in a significant decrease in implantation and then a significant increase in miscarriage. So the problem is dual. On one side you have decreased implantation, and on the second one, increased miscarriage. Most probably the problem is more on the side of miscarriage than on the side of implantation. So the classic problem of the patient with adenomyosis is they conceive and they lose the pregnancy. Even with IVF. In fact, the classic problem with a patient with adenomyosis is they go ahead and do IVF because it's going to be the embryo and it's going to be a perfect embryo. They do the PGS, and then that results in a miscarriage. And you could see here, for example, in this analysis, there is about a double the chance of miscarriage in patients with adenomyosis. And that's like a significant change. And And this is not just one study. Multiple meta-analysis have showed that this is a very consistent result. And you can see there, in some, when you look at the majority of the studies here are on the right side of this graph, so you could see that it's, and there are some pretty good studies, pretty consistent with a large number of patients. So this is pretty reliable. So we do know factually that we observe a decrease in implantation and increase in miscarriage. So yes, there's no doubt that adenomyosis affects both implantation and miscarriage, even in IVF.
Mm-hmm.
I know you asked me about what are we going to do, what to do about it. And do you have any specific questions or something you want to ask?
I guess as far as some of the medications, the different treatments, personally, I had a lot of failed IVF cycles for adenomyosis related stuff. And I know the medications recommended keep kind of increasing with every cycle. So can you speak to, at your practice, do you find some of the medications help? Are there treatments that help that people should look into?
Well, the first thing that we need to consider is, well, the first thing I'd like to say is that there is hope. I think it's very important to, we don't want to be all completely, we don't want to be negative about it. And although like the chance, when you're looking at the overall numbers, we know that adenomyosis has an effect. Overall, there is a realistic chance of success with treatments, with and without treatments for adenomyosis. And we can look at the treatments in a little bit, but I would say that it's not a hopeless situation. One thing that I have to say is that there is no, there are so many cases that I have personally seen in my personal experience where I thought, oh my God, this is the worst case of adenomyosis I've ever seen. And then these patients like surprised me and turned around and got pregnant on their own and were successful. So I can't, one should never say never, and there should be an understanding that that this is, I'm just gonna go back to our stop sharing. We'll look at some other images in a minute, but at least you could see me and our attendees can see me. But, so there's no doubt that there's hope for patients with adenomyosis. They can be successful, they can be pregnant. It's not an absolute risk for infertility. But the question is what to do, okay? And I think that it comes down to the history. It comes down to the extensiveness of the disease. It comes down to patients' choices and decisions. One of the things that I have seen, the most common thing is that people just start doing endless IVF cycles, one after the other, after the other, after the other, after the other. And that, the paradox is that although IVF is obviously an accepted treatment for subfertility related to endometriosis, the actual stimulation part of the procedure, where you're taking these hormones to stimulate the ovaries, actually makes the endometriosis worse. So it's one of those paradoxes where the treatment makes things worse. So because it increases inflammation by stimulating the adenomyosis itself. So one of the things that need to be considered is that what are the processes that can be done to abate this and what can be done about it, okay? For sure, one has to consider the fact that a fresh embryo transfer in patients with significant adenomyosis, where adenomyosis is the main diagnosis, is not a good idea. Mostly because that's like the most inflammatory moment, because you're just coming out of a stimulation and you're going to definitely have a reduced implantation rate with a fresh embryo transplant. And so I definitely would recommend that anybody considering or undergoing IVF should speak to their doctor and consider doing a frozen embryo transfer. So embryo banking first, then letting some time go by to let things cool down, and then a frozen embryo transfer.
Mm-hmm.
So that should be the first step. The second step is considering a time of cooling down after the retrievals to let the adenomyosis calm down. And, you know, some form of hormonal cool down should be considered.
Mm-hmm.
You know, high dose progestins, for example, is probably the best option. You know, they will sort of calm things down. Even a high dosage norethindrone, you know, and that, you know, maybe up to 6 weeks to let everything come down before doing an embryo transfer.
Mm-hmm.
The other thing that needs to be considered is whether or not some sort of immunological management, if you know, after failures, if you don't succeed, is there any benefit to considering some form of immunological management of this condition? Now, one of the problems is that a lot of reproductive endocrinologists don't, quote unquote, believe in treatments that are geared at suppressing the immunity to some degree. And so you may find some resistance, but I would say that certainly in patients with significant adenomyosis, you are going to find where you have hit a wall, some level of immunological investigation and immunological treatment with high dose prednisone or other sort of immune modulants should definitely be contemplated to increase implantation and decrease miscarriage rates. And I'm not saying that this should be the first sort of treatment, but it should definitely be considered. And I know you're going to talk about diet and other factors, which are obviously essential. But, you know, I'm assuming that you've done that already. You understand that? I mean, the point is that that's just like, you have to do that. But in terms of immunological considerations, it has to be considered. Because I can tell you in many of our patients who we have assessed immunologically with our immune evaluations, we see most of their inflammatory cytokines, especially the IL-17 cells, interleukin-17 cells, which we know are connected to implantation failure and miscarriage, those are sky high. And so, like, some form of immune modulation has to be implemented for these patients to increase implantation and reduce miscarriage. That is, in my mind, that's just like essential.
Yeah. So the high dose prednisone, don't you find that there's a lot of side effects though from that, from over, you know, that they recommend for 3 months as in the beginning of a pregnancy?
Well, so does chemotherapy. You understand
Yeah.
that? I
Yeah.
mean, you know, if you have cancer, the point about it, like, it's a price you have to pay in order to achieve the result. You know, I don't really, you know, I don't think anybody takes these medications. You know, what I don't believe should be done is just to give these medications. You know, what a lot of doctors seem to be doing is they tell people, oh, take a little bit of prednisone, take a little bit of this, take a little bit of Lovenox, take a little bit, they just give it like in very small amounts, subtherapeutic, and just because to try or because the patients are pushing for it. But in reality, if you're going to use a powerful medication, you should use it in the adequate amounts. And whether or not there are side effects, that's just, you know, the reality of using powerful medications. It's just,
Definitely. Yeah.
you know, but yes, of course, yes, these are powerful drugs that have a lot of side effects.
Yeah.
Of course, if you're yeah, go ahead, please.
Oh, so the high dose prednisone, and can you give an idea of like how great it would up the success rate of, say, pregnancy succeeding for adenomyosis?
Well, you're looking at abating really the risk of miscarriage. Ultimately, that's your that's the area where you can have the greatest intervention.
Mhm.
And at least in our patient population, we know we can at least half that.
Hmm.
And so that's a very significant intervention.
Huge.
And what I've seen is that, and I've seen patients with adenomyosis actually who ended up doing egg donation.
Yep.
Because ultimately they get pushed so hard, and they, and then the doctor says, well, you're not getting pregnant with your own eggs. We don't know why, but just do egg donation. And then they fail also egg donation. So I've seen that so many times, because in reality, it's not about the embryo. So really, that's really what it is. I mean, the doctor gets so focused on the embryo, but in the end, that's really where the issue is. And here we're talking about patients with significant adenomyosis, of course, that is visible, both by either ultrasound or MRI. And I'm sure some of your, other speakers will talk about that, but it's essential to consider that he has to be diagnosed properly. And if he's not diagnosed properly, then, you certainly have an issue there. But, I think that, like I'm saying, it's not the first intervention that you're going to do, but for patients with real significant adenomyosis, I think, who are being managed by in vitro fertilization, embryo transfer, those are the interventions they need to do. Frozen embryo transfers, and some sort of immune management, to try to suppress inflammation to some degree. But obviously, as you know, I'm a reproductive immunologist, so I don't advocate just throwing prednisone at people, because then if they don't succeed, then you don't know why, and sometimes people give not enough, or just they don't follow it, or they just do it because the patients push, but sometimes it's just not managed properly, and then you're just sort of back to square one, and that's like the big dilemma.
Definitely. And so does adenomyosis, does it always progress? This was a question from Instagram follower. Does it always get worse throughout your life, or?
Well, I don't want to be negative, but the answer is yes. It's a progressive condition.
Okay.
And in fact, in my mind, is more progressive. Significant adenomyosis tends to be more progressive than endometriosis.
Yep.
I think it's because of this constant, sequestered inflammation, and the fibrosis that occurs around it that just kind of keeps on progressing. So I just don't think it's a kind of condition when it's severe that just like by watching it is going to get better. It's just like one of those situations where you just sort of have to address it. And that's sort of how that is. After a while, the uterus looks like the muscle doesn't even look like that. It looks like a rock, and I have, if you want, for our viewers, I have a video to show, but it's very sort of, a trigger warning here because it's a little bit scary, but I think it's important to see what actually it looks like. So I'm going to go ahead and share my screen, okay? But trigger warning, look away if you're sensitive, okay, to these images. Can you see my screen?
Yes.
I was saying, in the most simple sort of like appearance, sometimes you'll see something like that. You see those black dots there? That's the adenomyosis sort of popping out, okay? That's what it looks like inside the uterus, okay? When it's truly inflammatory. And I'm gonna show you a video, which is a little bit scary, but I'm about to cut into a uterus that has adenomyosis, and you're gonna see black fluid popping out. The uterus is compressed, and there's like chocolate-like fluid coming out. Can you see the image?
Yes.
You see that? That's an instrument, that's a cutting instrument. This is the uterus. It's an open surgery. And you see that black stuff? That's like, look, you see that? I'm squeezing it. You see that stuff? That's not blood. That's like chocolate fluid, like endometriosis fluid. You see that? Isn't that crazy? I'm gonna play that again so you guys could see it. You see that?
Wow. Huh.
Yeah, it's kind of wild actually.
Yes.
But what I really wanted to show you is this, which, lowering the volume because I was probably commenting on it. This piece, you see, these are pieces of adenomyosis from the uterus. It looks like a rock. There's nothing, it doesn't look like a fibroid. It doesn't look like uterine muscle. It looks like rock. You see that?
Yeah.
It's just like a rock, basically. Which brings us to the consideration of, is there aggressive management of adenomyosis surgical indicated in the fertility patient? You know, because obviously, you know, a lot of doctors are going to talk about hysterectomy, but you know, there is a radical procedure that's called the Osada procedure, which is a surgery where you could actually basically, you could take the uterus and shell out the whole area containing adenomyosis, empty it sort of like, and then reconstruct the uterus in a very complex way, kind of like I'm going to switch back to my image. You're going to switch it around just like that, just kind of like wrapping itself up. You open it, you shell out the disease and you close it like that. And is there any benefit fertility-wise for doing this very radical operation? And the answer is, it's not clear. We don't really know. What we do know is, and I perform this procedure, it's called the Osada procedure, only in cases where the patient is so debilitated, so incredibly debilitated that is not able to function, and the only option would be a hysterectomy. And this is like sort of the second best option to a hysterectomy.
Okay.
But unfortunately, the Osada procedure carries, you know, some risks on itself, because, you know, the fertility is probably going to be somewhat reduced, as is reduced with the adenomyosis anyway. And there's some risk of uterine rupture in pregnancy. So, which has been documented mostly in Japan, where they've done a lot of this procedure. And it's a big operation that requires an open surgery. So like, it's not like something that somebody could take lightly in general. So only people with the most severe conditions are going to go for that.
Okay.
But, you know, certainly it is another option that can be considered. But, you know, and I know how we arrived here, we were talking about, I lost my train of thought. We were talking about fertility and the surgical, and yeah, I'd like to say one more thing, and I'm going to allow my, you know, other panelists to talk about this, but I'll just glance on it, that adenomyosis is associated with endometriosis. There's a very high association. So sometimes you will see a significant benefit in fertility if you remove if you go for the endometriosis surgery.
Okay.
Leave the adenomyosis alone, take out the endometriosis, because that will bring out some inflammation down, and then go for whatever IVF treatment you're considering doing, whatever fertility treatment. So that's certainly another option that can be considered.
Yeah. Do a lot of patients you see do the Osada procedure, or is it just you?
It's not about the patients don't do it or don't do it. I mean, I think it's an extreme solution, and I think it's only for extreme cases. Okay. That's why there's very few people doing it. I mean, I do it because I sort of like have a very selected population, and I myself have done a few. So it's not something that you do very commonly. Okay. Also because, like I said, it's a big open surgery. You can't really do it laparoscopically or robotically. So you can, but you're not going to do as good a job. And there's a risk of blood transfusion. So it's not like a small surgery. Okay. So I think it's one of those surgeries that are just done in cases that are, you know, very, very significant, where people really are told, look, your only option is a hysterectomy, period. Right. And they see multiple doctors that tell them that, and like, you know, they don't want a hysterectomy, obviously. And so, you know, they just go for a more conservative approach. Well, we know that procedure is good in order of improving the symptoms. There's no question about that. It works. But, you know, frankly, then if you have it, the question is that you need the reason to maintain the uterus, in my mind, would be to maintain a functional uterus, right? And so, like, that's really where you just want to be careful who's selected for these procedures.
Okay.
And so that's really the big dilemma for the OSADA procedure and fertility.
Are there any other kind of surgeries other than hysterectomy or OSADA for adenomyosis that you do?
Well, I do the standard adenomyomectomy for focal adenomyosis. You know, you just go and you just kind of like, there's like a target and you get that area.
Yeah.
But I can tell you that those are not as frequent as one could think, because, you know, like the common cases that I see sometimes in patients with adenomyosis, we're talking the fertility, also in the pain, is that you'll see an island of adenomyosis deep into the uterus in a difficult to identify area where, you know, you're gonna have to cut into the uterus and just sort of like in an expedition to try to find this thing. And maybe you don't find it. So it's not exactly that simple a procedure, and it's not exactly that successful a procedure. And certainly if it comes down to pure fertility, I don't really advise people to do that. You know, I think the adenomyomectomies that doctors do are just, they think it's a fibroid. They go in there trying to get a fibroid out, and then they're like, oh, it's not a fibroid. You know, it's just, it's a typical situation where the doctors, you know, it's less frequent now because most doctors have an MRI now where they're gonna go for a myomectomy. But if you don't do an MRI and you're not very careful, you could end up like discovering that it's not a fibroid and it's adenomyosis, which I see. I mean, I see people, it doesn't happen to me, obviously, but I've seen it happen quite often. So yeah, and I think my colleagues will talk more about the surgical aspects of it, but I think, you know, if there are some take-home points is that, look, I see it very frequently. Like to summarize a little bit, you know, what we've been discussing is, number one, adenomyosis is an inflammatory condition. It causes both inflammation and it changes the architecture of the uterus. The inflammatory changes affect implantation and increase miscarriage. The constant inflammation distorts the anatomy of the uterus and creates a changes in the vascular architecture. You're going to see blood flow issues. When you do the Dopplers of the lever uterine arteries, you're going to see increased resistance in the flow into the uterus. It changes the contractility of the uterus because it's so distorted, hence pregnancy complications, preterm labor, typical, and preterm deliveries, and postpartum hemorrhage because the uterus can't contract because it's distorted. So you see all of those problems because of that, all those changes. Like I said, the best approach, I think, is conservative. Surgery to look for endometriosis. If there's adenomyosis, a small island that's visible, like the dot that I showed you on one of those images, you could go after that and repair the uterus. Then IVF egg retrieval, if indicated, if people haven't tried naturally, and then some sort of a suppressive period afterwards, hormonal suppression, before going for an embryo transfer, like a couple of months later. And immune evaluation if you fail that, and potentially immune therapy. And just something that I wanted to mention, it just slipped. It was important, but it'll come to my mind. Yeah, sorry.
Oh, no, that's okay. I'll ask you a question while you're thinking of it. Can you speak to the cause of adenomyosis?
I don't think there's any clear science, but so far it's probably going to be the same as endometriosis. So probably the cytomatic theory is probably the most reliable theory, which is that these cells are there and it's a migration problem. They haven't migrated properly at the embryonal level, and then they start growing. And this is one of the reasons why you'll see this, like, you know, early in life.
Mhm.
So I think that's probably the most reliable. But you know, it's a real condition, and regardless of the origin, it's clearly a very serious condition that I think is very underdiagnosed.
It is. I think so too.
It's definitely underdiagnosed, and I see a
Yeah.
lot of people that come and the doctors are stumped and they don't know what's going on. It's kind of
Hmm.
crazy, actually, sometimes with gynecologists. They just don't see this. It's kind of wild, actually.
It is. Yeah,
Mhm.
I agree. Um, I guess, can you give us some hope as far as maybe a specific story of someone with adenomyosis that was able to get pregnant?
Oh, yeah. First of all, I have so many. Okay.
Okay.
I want to make it very clear that it is not a definitive no to pregnancy. I mean, I think that just as with endometriosis, you know, there is hope with adenomyosis. I've had cases that have come to me and who had failed so many IVF cycles,
Hmm.
and that with proper immune treatment succeeded. I've had people that failed IVF, then they did egg donation, they failed that,
Hmm.
then they came back and they got pregnant with their own eggs. I've seen it all. Okay. So, you know, I think that obviously this is not a absolute contraindication to getting pregnant.
Okay.
But obviously, you know, at some point, if the case is extremely severe and people end up needing a hysterectomy, which some people unfortunately have to, because
Yeah.
ultimately that is the only definitive treatment for adenomyosis, unfortunately.
Mhm.
You know, at that point, the only option is surrogacy. And as devastating as it is for a woman to, you know, having to not being able to carry her own child, I think it's sometimes a necessary compromise.
Yeah.
And I usually tell patients, you know, like if you're gonna consider surrogacy, you know, do it sooner rather than later, because sometimes I see people, they try so long and then
Hmm.
they end up like getting, you know, becoming older. At that point, they don't even have their own eggs, and at that point, they have to do donor egg surrogacy.
Yeah.
So, you know, it just which is another set of compromises. So I
Okay.
think that's kind of the dilemma. But I think, you know, obviously the problem with surrogacy is like it's big money, you know,
It is.
and
It's
huge money,
so
and you know, obviously there's ethical and moral and other considerations. But once you've overcome those, you know, you got to find the money, which is a huge amount of money,
it's just crazy.
right?
Yeah.
Unless somebody has a relative or somebody super
Hmm.
nice that they know that's going to do it for them, but that doesn't
Yeah.
really happen that often, unfortunately.
No, it doesn't. And then there's a whole host of legal issues you have to think about with that too. Kind of.
Well, rather than legal, I think it's
Yeah.
more like um, psychological, social issue.
Yeah. True.
Because,
Mhm.
like, from legally speaking, it is, you know, it is what it is, you know. But I think if you have your sister carry a child for you, or your sister-in-law, or your whomever, you know, a close friend, your high school best friend, your college best friend, you know, and I've seen it all, then like you basically owe that person, you know, everything. And every time you see them, it's just, it
Yeah.
becomes difficult. It becomes a very big emotional challenge. But,
That's
you know,
true.
it works sometimes very well.
Hmm. That's interesting.
And I
Yeah.
have people, and, you know, there's also international options. I've had people go to the Ukraine, for example, doing surrogacy.
Hmm.
You
Yeah.
know, India used to be there, but it's not there anymore. So now
No.
really pretty much the only option is the Ukraine. And there are some
Hmm.
decent centers there that I
Hmm.
work with, and people were
That's good to know.
successful. Yeah,
Good.
so it's
Yeah.
actually not too bad.
Huh.
There's
Yeah.
always hope. There's always hope,
There
no
is.
matter
Yes.
what.
Definitely. One last question I forgot to ask you was someone wanted to know about how estrogen and just hormones in general kind of interact with adenomyosis, and can estrogen make it worse, or how does that
Well,
all?
the answer is obviously yes. I mean,
Mhm.
one thing I can tell you is that, you know, if you have adenomyosis and your problem is pain, do not ever take unopposed estrogen. Don't use an NuvaRing. That's
Mhm.
that form of birth control pill. It's like a, because that's gonna just fire it up like very significantly.
Okay.
Some of your speakers will probably talk about the IUD, so I'm not going to just spend too much time on it because it's not really fertility related, but probably the best option in terms of temporary relief.
Yep.
But I guess you could do a whole hour of that. So
Agreed.
I'm gonna leave that for the next speakers. But I would say that yes, I mean, my biggest thing is what I see is that sometimes women are told, "Oh, you have adenomyosis, freeze your eggs," and maybe we should conclude with that, because I think it's that if you're a younger woman and you haven't tried to get pregnant, but you're starting to experience these symptoms, I think it's a pretty good idea to freeze your eggs, honestly.
Okay.
Mostly because the disease may progress, things may happen. So, it's something that may be worth doing if you are younger and you have the money. As usual, it comes down to that.
Yeah.
But, or your insurance covers it because you have like a wonderful employer like Google or something like that. But overall, I think that's certainly something that should be considered. If one is younger, and even if they're not considering pregnancy at the time.
Yeah.
So we should leave ourselves on that note, but also on a positive note. Like I said, I would say that the majority of patients will succeed, but it's a long journey. The problem is that even when you're looking at IVF now, people used to say, 3 cycles. Now they're saying 6 cycles,
Okay.
But who's going to do 6 cycles, 7 cycles, 10 cycles? I mean, I see it. But obviously, it's something that is difficult for people to even imagine.
Yeah, it's brutal. 6 cycles, I couldn't imagine.
Yeah, yes.
Yeah. Well, thank you so much, Dr. Vidali, for your time and all your wisdom.
Well, thank you for having me. And, I think it's an interesting topic. Thank you for organizing this.
Yes.
I think people would be very interested to watch this. And I'm curious to see what my colleagues will say. And
yes.
looking forward to watching it soon on, I guess we're going to see it on Facebook, right?
Yes. Yeah. Facebook and on my website.
Oh, fantastic. Okay, fantastic. Looking forward.
Yeah, definitely. Thank you so much. Have a good evening.
Bye-bye. Thank you.
Bye.
Bye.